we now move to another little chapter where we will deal with post-operative complications. And we're going to begin with a very common one, post-operative fever. And let me distinguish for you two variants that will be illustrated in the vignettes. You may see a question on the exam where either during the operation or very shortly thereafter, the temperature goes way up, 104, 105. And we're going to discuss a couple of examples of that. Or you might see a pattern where we're talking about post-operative days. Post-operative day 1 or 2 or 3, and a fever in a more traditional range, 102, 103, rather than 104, 105. So let me begin with a couple of examples of the first group. This will be vignette number 13 if you're reading with me from the book. Shortly after the onset of a general anesthetic, with inhaled halothane and muscle relaxation with succinylcholine, a patient develops rapid rise in body temperature exceeding 104. Metabolic acidosis and hypercalcemia are also noted. A family member died under general anesthesia several years before, but no details are available. Let me analyze this vignette with you. In fact, I'm going to go beyond the issue of postoperative fever to a little example here, just simply strategy on the exam. When you begin reading this, you realize this is a patient undergoing an operation. And it points out in the first line or two that he is with a general anesthetic, and they specify the agents: inhale halothane, muscle relaxation of succinylcholine. At that point in your reading, you already know this is going to be an anesthetic complication. Because if the intention of this exam question was to lead you to a point where the surgeon makes a hole in the vena cava and the patient bleeds, it wouldn't matter what anesthetic agent was used. So that degree of detail, this particular inhalation agent, this particular muscle relaxant, you know this is an anesthetic complication. And indeed, you probably already recognize, because I read the entire vignette, that this is a very famous thing that anesthesiologists fear, that is called malignant hyperthermia. It happens to be a problem and runs in families. That's why a relative had died on an earlier surgical misadventure. And the problem is the patient lacks one of the enzymes necessary to metabolize the two agents that were mentioned. And so rather than becoming relaxed like we do prior to an abdominal operation, the patient gets stuck at that level where there is muscle twitching without getting to the muscle relaxation. That generates a tremendous amount of heat, and that's why the temperature is going way up. So in terms of management, you do things that are obvious for somebody with a high temperature, like cooling blankets. But you also need to look at some of the other issues. We have to stop those muscles that are twitching. This is done by using a different kind of paralyzing agent, dantrolene. You put the patient on 100% oxygen, you correct the acidosis, and watch out for myoglobinemia, myoglobinuria. Because during the process of all this muscle twitching, the muscles may be damaged sufficiently to leak out the myoglobin and lead to myoglobinuria. Now the next vignette is a little different setting, but it's still in that group of very high fevers shortly after an intervention. 45 minutes after completion of a cystoscopy, a patient develops chills and a fever spike to 104. This is a classic situation. When we intervene in the body with a procedure, often a urological procedure, if there is an infection in that organ that we are instrumenting, we may send those bugs into the bloodstream. And this is classical. This is bacteremia. This is septicemia. And the answer you're looking for, obviously, is to take blood cultures, which we typically do sequentially 3 times, and then start empiric antibiotic therapy, and as soon as you have the culture results, perhaps switch to the appropriate antibiotic. And with that, we're going to move now to the other more traditional types of postoperative fever, the ones that are measured in days, 1, 2, 3, 4, 5 days after an operation, and where the range is 101, 102, 103 rather than 104 or 105. And before I go into the vignettes, I'm in fact going to show you one of the mnemonics that we often use. So we're going to cut away from my face and we're going to go to a screen that is going to illustrate for you the 4, some people say 5, W's of postoperative fever. Let's go through this. We think of 4 words: wind, water, walking, and wound. And perhaps a 5th set that I'll explain in a minute, wonder where. And then we put numbers. We put day 1 after wind, and day 3 after water, and day 5 after walking, and day 7 after wound, and day 10 after wonder where. And each of these is meant to help us remember the most common source of postoperative fever in those days that are listed. So if a patient has fever on postoperative day 1, it's probably atelectasis. And you are reminded by the W of wind. He's not moving the air in and out. But if the fever begins on day 3, a urinary tract infection is a better choice. Water reminds you of the urine. If it begins on day 5, on the other hand, is deep venous thrombosis because the patient is not walking. But if it shows up on day 7, you ought to be thinking of a wound infection. Now, the wonder where is an interesting one. It's a deep abscess. Now, how does that become wonder where? Well, CT scans and sonograms are relatively recent technological advances that many older physicians did not have during their practice. So they would see a postoperative patient. That patient was roughly 10 days after the operation. He would start spiking fever, and we knew that meant there was a deep abscess in the body somewhere. But that deep abscess might be subphrenic, subhepatic, pelvic abscess, intraloop abscess. And when we had only X-rays, X-rays could not see those abscesses. And so we thought, we know this patient has an abscess, but I wonder where this abscess is specifically located. That's where the W's came. Now, you don't have to wonder. You see a patient with day 10 post-op fever, you immediately order a CT scan, and you will see the abscess. So with this background of the famous W's, let's now move to the vignettes. We're now on vignette number 15. In the first postoperative day after an abdominal procedure, the patient develops a fever of 102. Well, this is happening on day 1. You think immediately of atelectasis. You listen to the lungs, you do a chest X-ray, and you have an example now on the screen of what atelectasis would look like on a chest X-ray. And then you treat the patient by helping him breathe and cough and keep his lungs clean, postural drainage, incentive spirometry, and if necessary, the ultimate therapy for very recalcitrant atelectasis would actually be bronchoscopy to remove the mucus plug. Now we move to vignette number 16, which is sort of an extension of the one we just read. Because if we are not successful in our therapy for atelectasis, then another problem supervenes, which is pneumonia. This was not in the W's. In the first postoperative day after an abdominal procedure, a patient develops a fever of 102. The patient is not compliant with therapy for atelectasis. And by the 3rd postoperative day, he still has daily fever in the same range. Now, this is not something that makes you think of urinary tract infection. You think of urinary tract infection when there was no fever on day 1 or day 2, and your first indication of fever is on day 3. But this patient has had fever from day 1. He needs now chest X-ray again, sputum cultures, and appropriate antibiotics, because this is now pneumonia. And with that, we move then to vignette number 17. A patient who had major abdominal surgery is afebrile during the first 2 postoperative days, but on day 3 he has a fever spike to 103. You're now thinking of urinary tract infection. Do urinalysis, do urinary cultures, treat with the appropriate antibiotic. On vignette 18, we have a patient who had major abdominal surgery, afebrile during the first 4 postoperative days, but on day 5 he has a fever spike to 103, and you think of deep venous thrombosis. I have now on the screen for you a venogram that demonstrates deep venous thrombosis, but I should point out to you this is for illustration purposes only, because typically on a patient like this you do not order a venogram. You do a much less invasive test, Doppler studies, and you get that patient to move around and, if necessary, put him on anticoagulants. And then we move on to vignette number 19. A patient who had major abdominal surgery is afebrile during the first 6 postoperative days, but on day 7 he has a fever spike to 103. You have every reason now to think of a wound infection. And physical examination of the wound is what you have to do. Now remember, we had the 5th of the W's, the wonder where. Let's read that one, vignette 20. A patient who had major abdominal surgery has a normal postoperative course with no significant episodes of fever, until the 10th day, when he begins to spike temperatures up to 102 and 103 every day. You know this is a deep abscess. It might be subphrenic, subhepatic, pelvic, intraloop, and you know what to do also, because you don't need to wonder where presently. You do a CT scan. You might do a sonogram, but probably a CT scan is your best answer. And with that, we'll leave the postoperative fever and now move to another subheading that has to do with chest pain. Let me give you a little summary before we read the vignettes. There are 2 conditions that may produce significant, alarming chest pain after an operation. Conditions where a patient suddenly gets severe chest pain and gets short of breath, and the patient thinks he's going to die. And these 2 conditions are an MI, a myocardial infarction after surgery, or a PE, a pulmonary embolus after surgery. Let me alert you to the first clue as to which of these 2 you may be dealing with as you read an exam question. And that is, at what day after the operation is this thing happening? Because the vast majority of perioperative MIs happen either during the operation or within the first day or 2, whereas the vast majority of pulmonary emboli happen considerably later, after the 5th, 6th, 7th day. So that when you read a vignette of a patient with post-op alarming chest pain, you immediately are directed into one or the other of these 2. Let's read the examples. We're now on vignette 21. On the 2nd postoperative day after an abdominal perineal resection for rectal cancer, a 72-year-old man complains of severe retrosternal pain radiating to the left arm. He also becomes short of breath and tachycardia. This is happening on day 2, too early to be a pulmonary embolus. So you immediately are thinking this is a myocardial infarction. And you proceed appropriately in your workup. You do your EKG, you do your cardiac enzymes, and remember the cardiac enzyme we rely on primarily nowadays is the troponins, okay? So EKG and troponins, if you identify that yes, this is an MI, then you provide supportive care. And I have to point out to you that one of our best therapeutic options for an ongoing MI is not available to this patient: clot busters. You know, the activated enzymes that dissolve existing clots could not be used in a postoperative patient. They would lyse every clot that is keeping him from bleeding to death. So we can only provide other supportive measures, or if available, perhaps, an emergency angioplasty and stent. But the treatment of a post-op MI cannot include the activated enzymes that dissolve clots. And remember, this is not the same as anticoagulants. A post-op patient can be given heparin if needed, or Coumadin if needed. Those do not dissolve existing clots, but you cannot give clot busters. All right? Now, having made the point that the typical MI after surgery happens within the first couple of days, I have to add that very often they happen, in fact, during the operation, when the patient is anesthetized. Let me read the vignette. This is vignette 22. During the performance of an abdominoperineal resection for rectal cancer, unexpected severe bleeding is encountered, and the patient is hypotensive on and off for almost 1 hour. The anesthesiologist notes ST depression and T-wave flattening in the EKG monitor. Now, don't pay any attention to the specific EKG tracing details, because what I'm pointing out here is primarily that when a patient is undergoing surgery, the biggest, the most common precipitating event for an MI is in fact severe bleeding and protracted hypotension, which this gentleman had. And the first indication of an MI obviously will not be chest pain. The patient is anesthetized. It will be the changes in the electrocardiographic tracing that the anesthesiologist will note. And so at this point then, a more formal EKG would be done. The cardiac enzymes would be obtained. We're talking about troponin, because this is obviously an MI even as we are still in the operating room. Let me now move to the other situation that we were talking about. This is now vignette 23. On the 7th postoperative day after pinning of a broken hip, a 76-year-old man suddenly develops severe pleuritic chest pain and shortness of breath. When examining, he is found to be anxious, diaphoretic, and tachycardic, and he has prominent distended veins in his neck and forehead. This is a pulmonary embolus. You already began thinking about the instant you read, on the 7th postoperative day, the patient gets the pain. But you realize again, this is an excellent candidate. An older patient with a broken hip, he's not moving around, he's not walking. And then you have all of the characteristics of a pulmonary emboli, including the fact that he's got prominent distended veins in his neck and forehead. The blood gases would show a very, very helpful pattern, because what we see after a PE is hypoxemia with hypocapnia. That is low PO2 and low PCO2, which is not what you see in pulmonary failure. In pulmonary failure is low PO2, high PCO2. When you see those two together, hypoxemia, hypocapnia, boy, that goes with a pulmonary embolus. And then we move on to what has become essentially the way to diagnose a PE, and that's a spiral CT scan of the chest. We may help the image by putting a little dye intravenously. So when the CT scan is done, the dye already has gone through into the pulmonary artery, and it helps us see the clot. But this is not a formal pulmonary angiogram. A formal pulmonary angiogram is always mentioned as, quote, the gold standard, end quote, to diagnose a pulmonary embolus. But it's not, in fact, what we do clinically. I have a picture for you here of what a pulmonary angiogram would look like on a patient that has had a pulmonary embolism. But let me emphasize, you know, this is a formal angiogram because you can see the catheter that has been inserted into the pulmonary artery. But this is not what we do clinically, okay? Clinically, we do the blood gases and we do the spiral CT. Now, some people refer to that, the spiral CT with a little dye, as a CT angio, but that's not the same as a standard angiogram. So now that we have the diagnosis, we move on to the management. And the management essentially begins with putting the patient on heparin. This isn't going to do anything for the clot that's already in the pulmonary artery, but it will prevent new clots from going to the lung. The one that is already there, the body will eventually lyse. And if the PE recurs while the patient is anticoagulated, or even if there's a situation that precludes the use of anticoagulants, then we have another weapon at our disposal, and that's to deploy a filter in the inferior vena cava. We now move to other pulmonary complications. Let's read vignette number 24. An awake intubation is being attempted in a drunk and combative man who has sustained gunshot wounds to the abdomen. In the ongoing struggle, the patient vomits and aspirates a large amount of gastric contents with particulate matter. This is the nightmare of every anesthesiologist, because aspiration, which is what this is, can kill a patient right away or produce chemical injury to the tracheobronchial tree with subsequent pulmonary failure and even secondary pneumonia or even later death. Prevention is best, and this is why typically prior to an operation the patient is instructed not to eat or drink anything for a number of hours. But you know, sometimes we have to do emergency surgery on a patient that has a full stomach, and these things can happen. If they happen like this vignette describes, the key to helping this individual is to wash out the tracheobronchial tree, to remove all the particulate matter and the acid, and this is done with the help of bronchoscopy. So look for the answer that says bronchoscopy and washing of the tracheobronchial tree. There is a line in your notes, if you're reading with me, that says it's too late for steroids to help, because at one time there was some enthusiasm for the use of steroids to minimize the chemical damage to the tracheobronchial tree, but unless the steroids are given prior to the insult, they are not helpful. And the last of the vignettes that have to do with pulmonary complications, vignette number 25, reads, a man with advanced pulmonary tuberculosis is undergoing a laparotomy for resection of a perforated terminal ileum secondary to intestinal TB. Halfway through the case, it becomes progressively difficult to bag him. This means the anesthesiologist is pushing the air in by pushing on the bag that has a gas mixture. And his blood pressure steadily declines while the CVP steadily rises. And there is no evidence of intra-abdominal bleeding. Now, the key to remembering what this might be lies in an earlier vignette that we have discussed. We had mentioned during the trauma review that if a patient with multiple rib fractures needs to be placed on a respirator, that as a precautionary measure we put chest tubes, because we fear that once we're blowing the air into the lungs at positive pressure, if the lungs were punctured by the broken ribs, the air is going to leak out and a tension pneumothorax is going to develop. And that's exactly what this gentleman has. This individual has developed a tension pneumothorax during the operation. Now, he didn't have broken ribs, but he had TB. The tuberculosis damaged his lungs. He has the blebs from the damage from the TB, and now that air is being blown in by the anesthesiologist bagging him, some of those blebs are broken. The air has now escaped into the pleural cavity, and he has developed a tension pneumothorax. That's why his blood pressure is going down, his CVP is going up. And he needs that air out of there, which a surgeon could easily do by having a needle putting it up through the diaphragm. Let the air out, and then at the end of the operation, a chest tube would be placed.